Okay, so we got that straightened around. So, like I said, every good Zoom conference has some technological difficulties. We got ours out of the way right at the beginning. So hopefully that's a good look into the future for the rest of this thing. So we're going to talk about exactly what is pelvic organ prolapse, what are the symptoms associated, and then we'll review the different types of pelvic organ prolapse and what we can do to help alleviate the symptoms associated with prolapse. So the best way to think of pelvic organ prolapse is these are essentially hernias into the vaginal space. So you can see on the diagram here, it's sort of a cutaway side view of the pelvis, looking at the bladder as well as the uterus and the rectum. And essentially, pelvic organ prolapse is herniation of any one of those organs where they start to push the vaginal wall ahead of it. And the resulting symptoms that come along with that are the pelvic organ prolapse. So it can be any one of those organs involved. Super common condition, like we mentioned earlier. Up to 50% of women may suffer from pelvic organ prolapse in their lifetime. So I guess the key message is that you're certainly not alone if you have symptoms associated with pelvic organ prolapse. These are a super common problem. And you can pretty much blame your children for it for most of these cases. So that's always nice to have something else to blame them for. We're going to go through some of the causes, and that kind of leads into us blaming your children. They are one of the primary causes. Associated vaginal delivery can be related to the development of pelvic organ prolapse. So it's not the kind of thing typically where you see prolapse right away, but it's going to happen years later after vaginal delivery. Just merely the passage of time and gravity working against the support structures that hold up those pelvic organs can result in pelvic organ prolapse. It mentions prior pelvic surgery, probably the biggest one being hysterectomy. It's not that the hysterectomy itself causes the prolapse, but it can leave the top of the vaginal space at risk for prolapsing in the future, and we'll talk about that. Obesity, just being larger, the more weight pressing down on the pelvic floor can promote prolapse. Smoking, we all know that smoking has its downsides, and one of them can be weakening of connective tissue and support tissues, and that's where smoking can promote or lead to pelvic organ prolapse. When it mentions chronic lung conditions, they're typically referring to patients that have a frequent or repetitive cough or strain. That can promote it, as does chronic constipation and heavy lifting. Finally, there are some genetic factors. There are families that may have weaker connective tissue related to genetic disorders, or just some patients, the way they form their connective tissues is not quite as strong as other families. As far as the symptoms, I mean, the symptoms are really very obvious. I mean, once this starts to happen to you, you start to notice a bulge that wasn't there before, and it can be pretty alarming. Patients are fairly shocked when they develop prolapse, and they're not exactly sure what it is. So they'll notice that visible bulge or protrusion. That's probably the biggest thing. We do see associated loss of bowel and bladder control, which we'll cover. They do have pain listed on this slide, and I would say pain is probably a not as common associated symptom. In patients that have a pain that's significant, we're oftentimes looking for other potential causes. A lot of pressure, yes. Most patients describe a lot of pressure, but as far as pain from the prolapse, that's not really typical. So if someone is describing significant pain, we're really going to usually dig deeper to see what else may be contributing to that. It's not often that it's just the prolapse alone. Pain with intercourse definitely can occur as the organs prolapse into the vaginal cavity. They take away space, and that can promote discomfort when being sexually active. Sort of a low back pain or a dragging sensation is very typical. But the notation of feeling like you're sitting on a ball, and then sometimes it can literally be a ball that's protruding to the outside. So that can be very dramatic and obvious. lots of different types of pelvic organ prolapse, basically, assigned by what's prolapsing, and we'll kind of try to, give you some examples of that. So the first is a cystocele. So a cystocele is where the bladder is protruding into the vaginal space. And so on our little drawing here, we've got our little blue blob, and that's going to be our bladder because it's full of urine, which, unless you're a Smurf, that's blue. For us, it's usually going to be obviously yellow or clear, but they're showing this as a Smurf bladder. So Smurf bladder is prolapsing into the vaginal cavity, and the symptoms we get with cystocele are a visible bulge where that bladder is pushing the wall of the vagina ahead of it. Sometimes because of the kinking effect and where the bladder is dropped, it's difficult for the bladder to empty. So patients will start to, start performing toilet gymnastics where they're leaning forward, bending over, trying to help their bladder empty. So that's a cystocele. Vaginal vault prolapse on the next cutaway side view, where the marker is pointing, that's the top of the vagina. So on the other slide, they've got the uterus shown. And so vaginal vault prolapse is a condition that happens after hysterectomy. And for lack of a better way to describe it, it's like reaching in and grabbing the toe of a sock and kind of turning it inside out slowly. And it can turn, completely inside out where it's protruding outside of the opening of the vagina. And it's usually associated with a small intestinal hernia up at the top of the vagina that's pushing it along. So a rectocele is opposite the bladder. So this is where the rectum has lost its roof. And as a result of that, when the person strains or bears down for a bowel movement, the rectum pushes into the back wall of the vagina, and that can cause symptoms associated with difficulty passing bowel movements. And we call that obstructive defecation, where somebody is struggling, where this is not constipation. Constipation is where you're having infrequent, hard or packed bowel movements that are not happening very often. This is when you have a sort of a normal bowel pattern, daily, every other day, but and the stool consistency is normal, but it just doesn't want to come out. And you can see in the diagram, it shows that little pocketing effect where there's not a good roof over the rectum, so the pressure transmission gets all wonky, and as a result of that, you get trapping of stool. Some patients will even start to put their own fingers inside the vaginal cavity to push down on the rectum. We call that splinting, and that's something they either kind of learn to do on their own to help, or they're pushing on the outside to help with that. So those are the symptoms associated with a rectocele. We mentioned before about an enterocele. That's just a small intestinal hernia pushing into the wall of the vagina, and that can happen most commonly after a hysterectomy, where it's pushing at the top of the vagina, like we mentioned before. So now that we know what all this crazy stuff is, and we've given it all names, what do we do about it? And I guess that the first point is that we really don't intervene just because it's present. So if, say, you're having an examination by your gynecologist or urogynecologist or female pelvic medicine specialist, and they notice that you have a dropped bladder, a cystocele, or a rectocele, or vault prolapse, it's all about symptoms. So the mere presence of those findings, don't mean that you have to do really anything about it necessarily, unless it's causing you symptoms or bother, because otherwise they're really not dangerous, conditions, except in their very advanced forms. There are some times when they can cause some trouble, but mostly they're more quality of life impactful. It's all about symptom management. And then that kind of depends. Most of the symptoms are obviously going to be tied to the degree or severity of what's prolapsing. So the more severe they are, the more likely you are to be having symptoms associated. And then that determines, when it's time to try to intervene. And as far as what do we do about it, some of these things listed on this slide, as far as dietary changes to support weight loss, pelvic physical therapy, these are helpful things to try when you have early pelvic organ prolapse. So if, say, you had that examination and your pelvic floor specialist or GYN doctor or urologist tells you that, you've got a early stage fallen bladder, but you're not really bothered by it. If you have some extra weight that you're carrying, that might be a time to try to see if you could lose that to help, prevent it from progressing. Or you can, at that point, you can begin a pelvic muscle exercise program to try to strengthen the pelvic floor support. These options of weight loss and pelvic floor exercise and therapy really are not going to help the situation if you're to the point where you have a, symptomatic, bothersome, visible bulge. At that point, you can do Kegel exercises till the cows come home, and it just won't make the prolapse reduce. And you could lose weight, and it's not going to change anything typically. So at that point, if you've got a visible bulge or a visible protrusion of prolapse and it's causing you symptoms or bother, you're really down to two primary options. And the first is, a pessary. So pessaries have been around since the dawn of time in different forms. But I liken them to kind of going to a trip to the shoe store. So when you go and think about the use of a pessary, they come in as many different sizes and styles and shapes as you can imagine. There are shoes in the shoe store. So when you go to get fitted for one with your physician or their assistant to go through that fitting process, it's just a matter of trying to find the right size and style and shape and fit that provides you a good outcome. So a good outcome with a good pair of shoes is something that's comfortable, something that stays in place, something that doesn't fall off, something that helps your situation. So pessaries are very similar. If they're fitted well, they're comfortable, they stay in, they help your situation. And then beyond that, if pessaries aren't helpful, we have to consider surgery as the next option. The best choice for surgery really depends on lots of different factors. What exactly is prolapsing? How bad is the prolapse? How is your overall health? What are your risks for considering surgical intervention? Have you had prior surgery that may impact the plan for what to do? Sexual function is a huge component. This is obviously a very functional area. You have bladder function, bowel function, sexual function, all in this small space. So we take into consideration all of those factors as your pelvic medicine specialist to try to tailor the best operation to suit the problem, and then to keep your goals in mind about what we're trying to correct. So there's a million different procedures that we do for these problems, and they can range from reconstructive procedures, which include native tissue repairs, meaning using your own tissues and stitches. We're able to create a new floor under the bladder, a new roof over the rectum, a new support at the top of the vagina. The issues with native tissue repairs is that because you have weakened support tissues, that's why you've had this problem to begin with. Using your own native tissues, which have already demonstrated their weakness, resulting in these problems, these hernias into the vaginal space, using those weakened native tissues to create a repair sometimes doesn't give us the best long-lasting results. So as a result of that, we have adapted use of other techniques. One is the sacral colpopexy. Today, it's usually through a robotic laparoscopic approach, oftentimes done as an outpatient, as a same-day surgery or an overnight hospital stay. We also have adopted the use of biologic graft materials to help bolster that weakened native tissue to give us better or longer lasting repair options. So, what do you expect after surgery? I think, obviously every pelvic floor therapist has their own set of guidelines and rules. Usually, with the minimally invasive approaches we use to correct these problems, the need for a prolonged hospital stay is not typical. Every person's experience is obviously different, but it's not often that you have to have a prolonged hospital stay. Most people are either home the day of surgery or an overnight hospital stay and home the next morning. So what are the next steps? If you think you're having symptoms of pelvic organ prolapse, you just need to make an appointment with a pelvic floor specialist, and then talk to them about what's happening and what your options are, and then you should be able to tailor that to what your goals are about resolving the symptoms, and the symptoms will remain the focus of getting you better and beyond, and hopefully back to more normal life after that. I guess if anybody has any questions, we'll try to go through the chat questions if anyone has anything, and we certainly appreciated everybody jumping in and learning a little bit more about pelvic prolapse tonight, and obviously we're available if you have any other questions, and we'll try to go through some of those. Valerie can maybe tee up some of those questions for me if there are any.